So, hi everyone. It's 1 o'clock, so we'll start. My name is Natalie. I'm working with the Better Project as a research assistant. I'm really happy that you could join us today to hear about ways to optimize insulin adjustments for different types of meals. And thank you for being part of the Better Registry. We need your reality and to better understand T1D. So today we have two presenters. We have Dr. Yale, who is a professor of endocrinology at McGill University, and he's an endocrinologist at the McGill University Health Center as well. He chaired the clinical and scientific section of the CDA from 1992 to 1994. He chaired the expert committee that published the 2001 Canadian Diabetes Association Clinical Practice Guidelines for the prevention and management of hypoglycemia in diabetes. He was a member of the steering committee for Diabetes Canada Clinical Practice Guidelines from 1995 to 2019. His research interests include the prevention of hypoglycemia in type 1 diabetes, intensive management of type 1 and type 2 diabetes, and he participated in numerous multi-center trials. We also have Meryem Talbo. She's part of the Better Project, and she is a registered dietitian and a PhD candidate at McGill University. She analyzes the data from the Better Registry to explore the use of technology to reduce the burden of diabetes management. Her research focuses on comprehending hypoglycemia and its impact on individuals living with diabetes. She led the co-read T1D project, which aimed to collect clinical experiences from healthcare professionals and the lived experiences of individuals with type 1 diabetes. The goal was to formulate a list of suggestions to serve as the basis for clinical recommendation regarding insulin adjustment during meals. So if you have questions during the presentation, please use the Q&A section to ask them, and we will try to answer as much as possible at the end of the presentation. So Dr. Yale, Meryem, the floor is yours.
Thank you very much, Nathalie. Good afternoon, Meryem. Together we'll be presenting to you this event, Optimizing Insulin Adjustment for Different Types of Meals. I'll be starting by showing you the agenda. What we'll be discussing today is what do we know about carbohydrate management in type 1 diabetes? How do fat and protein impact my blood glucose levels? We'll look at what strategies that you can use for a mixed meal. And finally, there was a recent consensus conference and process called co-read type 1 diabetes, which was chaired and created actually by Meryem, and she'll be presenting this to us as well. Now, why are we interested in mealtime? Why do we discuss this? Well, of course, we know that the meals will have a big impact on glycemia. If we look at what happens during the night, it's usually much more calm. During the day, well, there's meals, there's physical activity, stress, etc., that affects. But of course, meal is a major influence on the fluctuations in glycemia and requires an intervention. You have to decide on a dose of insulin before every meal to be able to compensate for that. And it's challenging because it's multifactorial. There's, even within a meal, of course, there's a carbohydrate content that will influence. You eat more and you need more, but there's also the amount of protein and fat will have some effect, as we'll see. And as well, other factors that we're not necessarily taking into account, such as how fast do you eat? Some people take 2 hours to eat, some people take 10 minutes, and that has a big impact as well on the glucose effects. Now, one approach would be simple, would be to say for a given meal, I always eat the same meal every day, and I always take the same amount, and you'd be able to find the correct dose that seems to work from day to day. But of course, we can't do that. It would affect quality of life. It's important to vary what people are eating from day to day. Eating is a social event. It's a source of pleasure as well. So it's important to be able to adapt our insulin management to the food that we're eating rather than adapt strictly the food to a disease. I'll ask you a few questions now, and I would ask you to take your phone and scan this QR code. So if you're not familiar with that, you just take your intelligent cell phone, you put you go at the camera, and you aim towards this square. You will see a link that will appear. The link will be called Poll Everywhere. So you click on that, you'll go on the site. You don't need to register, just say skip this piece, and you'll end up having questions that you can answer. And I encourage you to participate so we can share together some impressions. I'll leave the square for a few more seconds. It will also be repeated if you take some more time to get to your phone, etc. On each question, the little square will be in the corner. So as you see the first question, you can start answering it, and we'll go there now. Seem to be blocked. Okay. So see people have started to respond. So we have a majority of people with type 1 diabetes on an insulin pump with us today, and others that are on MDI, multiple daily injections of insulin, and carb counting. And there's quite a few others, which I'm not sure what they are. I should have been more specific in my questions. So maybe in the chat you can tell us who you are with the other. The next question is for you to choose the sentence that best describes you. A, I don't use carb counting. B, I do a precise carb counting before calculating my dose with my insulin carb ratio. Or C, I roughly estimate the carbs with a margin of 10 to 20 grams of accuracy. Or I always use the same number of carbs for a given meal, it goes faster. So we'll allow the data to come in. We have a majority seems to be eyeballing by saying, oh, this is about 40 grams. This is about 60 grams. Seems to be the majority of our participants as it's still evolving. So thank you for that response. We're up to 80% doing that approach. And another question. Compared to a meal containing 40 grams of carbohydrates with little protein or fat, if I instead eat a meal with the same 40 grams of carbohydrates, but a lot of protein and fat, for example, pizza, I give the same amount of insulin because the two meals have 40 grams, or B, I give more insulin because the proteins will raise my blood sugar, or C, I give my insulin dose over a longer period because the fats will delay the absorption of the carbohydrates, or 1 in 3, I give the same amount over a longer period of time, or E, number 2, I give more insulin on a longer period of time, or F, I just enter 40 grams in the pump and the pump will take care of the rest, or I don't know, that's why I'm here today. So the majority seem to be giving the insulin dose over a long period of time because of the fats. So we'll see how this affects. Well, thank you very much for these responses. It's useful for us to sort of see what is currently. We see that the 2 and 3 is also gaining momentum at 22% now. So what I'll do, I'll stop sharing now and give the control to Meryem, who can continue with our presentations.
All right, do we all see the slides? Yes, perfect. Okay, hi everyone. Thank you for joining us this afternoon. So we will start first by trying to answer the first question. So what do we know about carbohydrate management in type 1 diabetes? So we agree, I think, across the globe that carbohydrates are a staple in diabetes management. They're very central as well. We need to focus on the carbohydrates to a certain degree because it is the main nutrient that raises our blood sugar after we consume it. So here, for example, Diabetes Canada recommends that we pay attention to that. And in terms of the guidelines that exist, we also talk about carbohydrate counting. So that's when we try to estimate how much carbohydrates there is in a meal or in a snack, for example. And a lot or most actually of people who live with type 1 diabetes and use insulin have an insulin to carb ratio that is usually tailored to their needs. Sometimes it's also tailored to the time of the meal. So you might have an insulin to carb ratio for breakfast that will be different from supper. So that what it does is that it offers us more flexibility in terms of the meal size and frequency of the meal as well, because we're no longer bound by a fixed dose. So it's not, if I have like 5 units that I need to eat for a meal, I usually have to tailor my meal to meet the insulin. In this case, when we have an insulin to carb ratio, it's the other way around. So it offers us more flexibility. That in turn also seems to result in lower insulin requirements because we adapt it to our lifestyle or to our meal consumption. It also has been reported to improve glycemia, specifically HbA1c. And that additional flexibility also improves the quality of life when living with type 1 diabetes. So while carb counting helps, it is not always very what is the word? It's not always going to help the post-meal glycemia to be well controlled. So sometimes there are other things that will also impact how glycemia after the meal will look like. So first of all, not all carbohydrates are the same. So we have simple sugars, we have starch, we have fiber, and all of these are carbs, but they're not going to impact our glycemia the same way. So we need to also take that into account. However, even when we do take that into account, sometimes after meal glycemia will also remain a challenge. And that brings to mind actually the thought of maybe there is something else that can also be impacting our glycemia in the meal. So maybe we need to step away or step outside a little bit of our focus on only carbs and consider other macronutrients that could also be impacting our blood sugar. So we do know in the literature now, there are a lot of studies that came out that do tell us that in fact, protein and fat, when we consume them, they also affect glycemia. So they will affect how fast it will rise. They also affect for how long it will remain high. So we can have a meal with the same amount of carbs, with the same time of carbs, compared, we can have two meals that have the same amount and the same type of carbs, but they will have two different blood sugar responses. When we eat a meal and we take our rapid insulin with it, the action of the insulin will be the same for those meals because it doesn't know that I'm eating protein with that meal or not. So it has to be our job in a way to match what we eat with the insulin. And just starting with being aware of the impact of proteins and fat on our glycemia could maybe help us in having some strategies to adjust the insulin dose accordingly. So first, we'll try to understand how does fat and protein impact our glycemia. So first, when we talk about consuming a meal, most often we consume what we call a balanced meal that is supposed to have some protein, some fat, and some carbs. It looks like the healthy plate that, for example, Health Canada recommends. And that balanced meal usually has a digestion time that aligns better with the rapid acting insulin. So you can see in the graph, we have the green line, that is the action time of the rapid insulin. And we also have the blue line, that is the sugar or the glycemia changes. And when these two fit closely, we can see that the glycemia is well managed after the meal. It also simplifies blood sugar management because if we know that's how I'm going to react to the meal, then it's easier to predict those changes, but it's not realistic to always eat the same thing all the time. Hence why we try to take into account also protein and fat. So protein affects glucose levels it has a moderate impact in the sense that, as you can see in the graph, there is an increase in glycemia after we consume a meal that contains protein and carbs. However, that increase is delayed. So the peak is delayed and it also lasts a little bit longer. So we have a delayed but sustained glycemic excursion. Similarly, the fat as well, it does impact glycemia. So when we consume a meal that has fat as well, there is a lower or delayed glucose rise after the meal. So we see in blue, the curve is more wide. So that shows us that there is a delayed rise, but the peak can be also the hyperglycemia peak will be sustained for longer as it delays the entry of the glucose into our bloodstream. So what happens when we have both high fat and high protein? So that's a mixed meal. That's a common thing that we can consume as well. And what happens when you consume these two together, there is a combined effect. And then it makes blood sugar go higher, even compared when we eat them separately. And there's also a risk of hypoglycemia because that delay in the increase in glycemia will not match the increase in the insulin curve, as we can see in this graph, and that will increase the risk of hypoglycemia, while at the same time increasing the risk of hyperglycemia later on, because the insulin has already finished its action and the meal or the glycemia is still rising up to 3 to 5 hours later on. So there are many strategies that we can use that have been reported in the literature, and I invite Dr. Yale to tell us about them.
Thank you, Meryem. So let's see, what are those strategies? Well, the first one we could look at is what we might call experience. So it's basically to determine the insulin dose by counting the carbs in the meal as usual, to ensure hopefully that the calculation is accurate. And then to monitor the blood sugar for 5 hours after a given meal, for example, rich in fat and protein, and seeing what it does. And if there is hyperglycemia that occurs, for example, late, well, to adjust the dose and timing for that specific meal when you'll eat it the next time. And over time, with experience, you come to know how much you need for a given meal. Most of us probably don't have 100 different meals. I mean, if we make a list, and it's often surprising how little they are different variations. But if you do a list of what you eat at home, you'll probably end up with 30 or 40 different choices, and maybe less, maybe more. Of course, there's always the unusual when you go to the restaurant or friends, but what you eat is... So if you do acquire experience with those 30 meals, you end up being much more able to adjust because you exactly know what would happen. So that's one approach. The other approach is to say, how can we have different strategies to adjust the insulin dose? What do we know from what's suggested in the literature? And we'll see later how to adjust the injection timing. So let's look at first how to adjust the dose. One way, which has been mostly recommended by the children's and adolescent associations, is to add a certain amount, a percentage. Depending on what's the meal, it could vary between 20 and 60% more insulin is needed when it's a mixed meal compared to a meal that contains less fat and protein. So what's recommended, since it's between 20 and 60, is to be conservative and add a 15 to 20% to the insulin that is calculated based on the carb counting if you're consuming a high-fat, high-protein meal. The advantage of this, it's simple. It's a simplification. No need to estimate protein and fat content. So you just say, I'm eating a lot of fat and protein. I'll add a little bit more insulin, 15 to 20% more to, to cover this. So that's one approach. The other approach is the fat protein unit method. This approach is based on the amounts of calories included in the meals. So what you do is you calculate the number of grams of protein and you multiply by 4. I'm sorry, I'm losing my voice temporarily. You can also calculate the number of grams. Meryem, I think I'll ask you to...
Yeah, I'll take this one. Yeah. So the other method that is reported in the literature is the fat protein unit. So it really is based on calculating or estimating how many grams are there in a meal. So it takes the number of grams, we multiply it by 4. Why do we multiply it by 4? It's because that's the amount of calories that we have in a 1 gram of protein. So it's sort of based on the calorie content. And we do the same for fat. So we take the number of grams of fat, multiplied by 9. We multiply it by 9 because that's how much calories there is in 1 gram of fat. We add these two results together and then we divide it by 100. And that gives us another unit called, the fat protein unit. And basically this is, we assume with this method that each FPU or each fat protein unit is equivalent to 10 grams of carbohydrates. And then we just use our usual insulin to carb ratio to calculate the dose. So we take however number of FPUs we have, transform them into 10 grams of carbohydrates, and then we use the ICR, and we give that additional dose over time after the... I think Dr. Yale is back.
Okay, so we'll try. So go to the next slide. So the advantage of this is that there's less hyperglycemia after the meals. But there's more risk of hypoglycemia because you're giving more insulin. I think I'm losing my voice. Sorry.
I
So,
can go ahead if you
so go
prefer.
ahead for
Yeah.
at least another slide. I'll try to.
Drink some water. So there is less hyperglycemia after the meals, which makes sense because you're giving more insulin. However, there is also an increased risk of hypoglycemia later on. So there has been a suggested modification where basically instead of dividing by 100, we divide by 200. So we're sort of splitting however units we were going to take by half. And this one does not have any, did not show any risk of hypoglycemia when we're consuming a high fat, high protein meal. But the risk of hypoglycemia was still present when they tried it with a normal protein meal. So like 30 grams of protein, that's about, for example, a piece of chicken breast, for example, that you would consume in one portion. So there is still some risk of hypoglycemia, even when we try to be very conservative with that. So here we just have an example of calculation, just because it's nicer to see it in a practical example. So we have here actually pizza. For one serving, we have 28 grams of protein, and you can see that in here. So we will multiply that by 4, will give us 112. Then we will do the same for fat. So we have 21 grams of fat here. So we multiply that by 9. Then we add the two together. It gives us about 300. So we divide 300 by 100. So that's the original fat protein unit method. It gives us 3 units. We can also divide it by the more conservative modified method by 200, and that will give us 1.5 units. So if my insulin to carb ratio is 1 unit of insulin for 15 grams of carb, if I take the 3 FPUs or the 1.5 modified fat protein units, I will be taking 2 units if I use the original methods of insulin. Or if I use the more conservative method, I will be taking 1 additional insulin unit for this specific meal. Good to go?
I'll try. I took a fisherman's friend, so if it will help. So another strategy is food insulin demand. That's a list of foods with how much insulin might be needed. So it's easier in the sense there's no calculations to be done, but it's a limited number of foods. I don't really use it in my practice. I don't know, Meryem, if you use it more, but it's another strategy that has been described in the literature. Next slide. The other approach is to just take into account the protein. So the protein, when you absorb it, is divided in amino acids. They can be used by the body to make glucose, by the liver and by the kidneys. And we consider that about 50 grams of protein is equal to 10 grams of carbohydrates. So one approach is to disregard the fat and just concentrate on the protein, and to therefore consider that you take the amount of protein, you divide by 10, and you consider that those are carbs, and you just put them into your insulin carb ratio. And then you give it before the meal, and you extend over a period of time to take into account the fat. In other words, you don't use the fat to decide on the dose, but you consider the fat to decide to give it over a long period of time, because when there's fat in the stomach doesn't empty as fast. It tends to want to finish digesting the fat and will keep the food in the stomach where there's no absorption. So we have to take into account that it's when you take some fat in the meal, it's like if you ate more slowly, the absorption will be over many hours. Another approach is to use regular insulin. So one approach when you divide is to take some right away and some later. The other approach is to use an insulin which is slower, the older insulins. You might remember the Toronto insulin for some of you. Well, those insulins are slower, so they imitate more what protein might do. The other approach we've discussed briefly is to adjust the injection time. That's mostly for the fat component. So as you see here, when there's a mixed meal, the absorption will be slower. Why? Because the stomach is not emptying as fast. And the peak will be longer and higher or more prolonged because there's a protein component, which with the amino acids slowly becomes glucose, but that process takes time. So The strategy is either to give the entire dose up front and hope that nothing happens. But if you want to adjust to a mixed meal, you might want to give less right away to avoid the risk of hypoglycemia if you give all the insulin at once and the stomach is not emptying. And then give the rest, the other third, over maybe a few hours later, 2-3 hours later. But when you're taking injections, that requires a second injection, which is not necessarily something everybody's willing to do, and it's more complicated. 2-3 hours later, you might be doing something else. The next slide shows that, and with an insulin pump, it's a little bit easier because you can instruct a pump at the time of the meal to do that. So you can either give the entire dose up front, that's the standard approach. So you say, give the bolus, it gives a bolus. Or you can ask the pump to say, give it over an extended period of time. So it will give it over a certain number of hours. Or you can do a mix of both, which is corresponding to what we said, where it will give half to 70% right away, and the remainder will be given over a number of hours. So that's a dual multi-wave bolus that can be selected in the menu, and then it reproduces that without you having to think a few hours later to give more insulin. If you're on a pump that is talking to your sensor and making decisions of giving you more insulin when you're high and less insulin when you're low, well, that offers additional flexibility because you still need to carb count, but a lot of the other adjustments the pump will probably do. So you can try to do it anyway, that is to instruct the pump to follow that. But if you don't, and if your sugar tends to go down right after eating, the pump will give less insulin to compensate. And if the sugar tends to go up late, a few hours after the meal, the pump by itself will give more insulin to compensate. So in a way, the system will adjust and will simplify your life at that level. But hypoglycemia might still occur right early, so you have to still be careful. Next slide. So the strategies exist, but we see they're complicated. There's complex calculations. Already carb counting is complex. You have to calculate your carbs, divide by your insulin carb ratio. Usually you have to add to that a certain amount to compensate if your sugar is high using the correction factor. It's a lot of complications. If we add more calculations now by saying calculate the fat protein unit, it becomes more complicated. And there are no specific recommendations. There's different publications that I've very briefly shown you, but there's no specific recommendations in the guidelines. And we know that there's not just a risk of hyperglycemia, but also hypoglycemia. So based on this, there was a desire to try to be more specific in the recommendations we can give to all of you that we're seeing. And that's where Meryem comes again into the picture. In her studies, she's created this consensus where she'll describe to you to try to see beyond the studies, what do people with experience suggest to do? So Meryem, I'll let you continue this part.
Thank you, Dr. Yale. I hope you can have a little rest for your vocal cords. Dr. Yale just presented to us a bunch of different strategies that do exist in the literature. However, we just want to keep in mind that these strategies were done in a controlled environment. So it was in a trial, in a study where the fat and the protein was calculated, which does not necessarily reflect what we see or what happens in the real world. So that's why we wanted to see what clinicians suggest, but also what people with type 1 diabetes who have that lived experience do in their day-to-day. So this project called Correct T1D is a consensus to propose recommendations for type 1 diabetes management. So as I mentioned, we gathered practices from both people living with type 1 diabetes and clinicians who work with people living with type 1 diabetes. We asked them a series of questions, and basically we set an agreement or a consensus to say that this item has been agreed on if more than 80% of the participants agreed with it. And we did this for 3 questions. Then we had a virtual panel meeting as well. So we discussed those different strategies. And I'm going to be presenting to you today some of the preliminary results. So I just want to make sure that I highlight that it's preliminary results. Please do not use this to take any medical decisions until it has been peer reviewed and revised. So first, what we were interested in, we wanted to see what were the insulin adjustments that people were either recommending or doing when they were consuming a high protein meal or a high fat meal or a high protein, high fat meal, either with standard carb or with a low carb content. If they were using injections, if they were using an insulin pump, or if they were using an automated insulin delivery. So we were also interested to see what was the definition actually that people had in terms of what is a high protein or what is a high fat meal, because currently, yes, we do have different definitions in the literature, but we don't really have an agreement on how to define a high protein or a high fat meal. So one of the first results that we have here is that we actually reached consensus to define a high protein meal is any meal that would contain 35% or more energy content from protein, or that will contain 40 grams or more of protein as a nutrient. Similarly, for a high-fat meal, it has been defined as either a meal that has 40% or more of its energy content from fat, or 30 grams or more of fat as a nutrient. So now that we have this definition, we then asked about the different adjustments. So this is for high protein meals, whether they are with standard or with low carb. So we'll see again for the insulin dose, it was recommended to use an additional dose that it could be needed when we're consuming these meals, which reflects what we found in the literature as well. One way to do that is to estimate how much protein there is and convert 25% of that amount to carbs, and then add that using the insulin to carb ratio. In terms of the distribution, it was recommended to split the bolus. So if you're using injections, take a certain amount at the beginning, then the rest in a second injection, as Dr. Yale mentioned, or if you're using a pump, to take it over 2 to 4 hours extended. In terms of for people who are using AID, it was recommended that we just take the dose for the carb count and the system will correct if needed, assuming it's in auto mode. For high fat meals, again, whether it has standard or low carb, the recommendation was actually to reduce the dose, especially if there is a risk of hypoglycemia, and monitor for up to 6 hours to see how the glycemia will change afterwards. For the distribution, it has also been recommended to take 60% with the meal and 40% that will be extended over 2 hours, or take half and half at the beginning and half that will be extended over 2 to 4 hours after meal. And this is where the experience really comes in and would be key to know what works for you and what does not work for you, and we can play this. So this is really just a place to start. For AID users, it was also recommended to either take the full dose and let the system do its thing, or to take a reduced dose, and again, just in case there is a risk of hypoglycemia, and continue monitoring as well for all bits of insulin adjustment intake. For when we're consuming a high protein and a high fat meal, the recommendations were that we need an additional dose, as we've seen with the protein, because there is an increase as well. It could also be just taking the regular dose and watching out if there is a hyperglycemia and correcting later on. In terms of the distribution of this dose, again, going to a split bolus, starting with a little bit higher, starting with 70%, and extending the remaining 30% for 4 to 6 meals. So here you see a more delayed or a more extended time that we will be giving this dose for. And this reflects, again, what we saw earlier, that compounded effect of fat and protein together, delaying the absorption. For AID users, again, we take the full dose, or for our usual carb counting and ratio, we'll let the system correct as needed. So if we put all of this together, what would be our takeaways? So the first thing would be to keep in mind that we can have 2 meals with the same carb content, but it will affect glycemia differently. And that could be because the meal's content of protein or fat will be different, and these combinations of different nutrients will impact our glycemia differently. So we need to keep in mind. Now we need to understand that protein will delay the glycemia rise and will increase it, while the fat will mainly delay the peak and hold it for longer. So once we understand these concepts, it will help us to sort of either react once we see that our glycemia is acting up, or take decisions before the meal so we can adjust our insulin accordingly. But we have to keep in mind as well that carb counting remains central for meal time management. We also have a list of resources actually on the Better website. So there's a QR code, and I think Natalie will share the link as well. And you can find on those different types of applications that could help you see how much, for example, just taking a picture and will help tell you how many grams are there estimate in your meal, but also it can tell you how much fat, how much protein is there, and you can use that to make your adjustments. We also want to talk a little bit about automated insulin delivery. So we do see this technology coming in. A lot more people are using it now. There's a lot more developments. So it is becoming something that is more and more used. However, we got to keep in mind that it still requires carb counting. So we are still a little bit far, not there yet, for full automation where we just let the system do its thing. We don't tell it anything, but we are getting a little bit closer. So there are some newer AID systems that are being evaluated, and we do have results in the literature about them. So there are systems where you no longer need to even tell the system how much carbs you're eating. You just tell it, I'm eating, announce your meal, and let it handle it. Or there are also other systems where we do a qualitative carb estimation. So we don't need the exact number. We just tell the device, I'm either eating low amounts of carbs or medium or high, or I'm eating my usual or more or less compared to my usual meal. And then the system will be able to adapt accordingly. So thank you for listening to what we put together today. And I think we can open it for questions. Natalie, you might be muted.
So should we go?
Okay, so we only have a few questions to answer your interrogation, Dr. Yale. One of the participants said he was a parent of a child, so I guess the others are probably parents. Here, I don't know which one of you want to answer this. Someone says, I have severe gastroparesis. How would I adjust in this case? My emptying is approximately 4 hours.
Maybe I can take this one to start. Gastroparesis is when the stomach is not emptying normally, because usually the way the stomach empties is controlled by a series of nerves that are linked to the brain and linked to the rest of the intestine system, etc. And when there's neuropathy, one of the neuropathies is that control, which is fairly complex, of emptying the stomach. So those people, the stomach is paralyzed. That's why gastroparesis, that's what it means. But basically it means that the absorption is a little bit less predictable. You mentioned your emptying is approximately 4 hours. If your emptying is fairly reproducible, then it probably actually, if you happen to have the chance to be on an insulin pump, will simplify the work of the automated pump because your absorption is slower. So the pump is able to follow, even if you miscalculate your carbs or even if you don't take into account the amount of protein and fat, the pump, because the things are changing slowly, will be able to follow you. Otherwise, if you go with if you're on injections, then often it's either to change the kind of insulin you take to a more slow one, or wait till you're finished eating before you inject, certainly. For many people that have gastroparesis, the difficulty is the reproducibility. In other words, some days the absorption happens normally, and some days it seems to be blocked in place. And that, of course, complicates things because then you have to wait. And based on that, we often say, wait till you finish eating, wait till your sugar starts rising, and then you know it's being absorbed, and you'll be able to then adjust. Some people have, when it's very severe, they sometimes vomit their meals, so that complicates things even more. So it's not simple. The good news is with extremely good glucose control, that's usually a reversible condition. I've had some patients that were vomiting like every 2-3 meals, losing a lot of weight, having a lot of difficulties, and with very strict glucose control, sometimes it comes back almost to normal. So it is potentially reversible, to give you some hope at that level.
Thank you, Dr. Yale. Meryem, did you have anything else to add or no?
No, to add to this question, no, it was pretty complete, I find. Yeah.
Okay,
But I can
great.
take maybe the next one.
Yeah.
See, can you define over a long period of time regarding insulin delivery? So yeah, so in when we were actually looking through the answers, the long period of time varied between 2 hours, 4 hours, 6 hours, 8 hours. So that's why we didn't have the numbers yet because we're still analyzing them. But if we were to look at it, it would be, for example, for a high protein, it would be between 2 to 4 hours. That's usually where we see the change. When we add in fat, it's up to 6 hours, and when we have protein and fat, sometimes it can go up to 8 hours. So it's really again when it depends also on the person and how fast their emptying rate is, what else is being consumed, what the type of the meal is. So it goes back to that experience of just paying attention and keeping in mind that based on your previous experience, you can build on for the current adjustment that you're trying to make. And for some people, it's 4 hours. For some people, it's 6 hours. So it's those are the numbers that we've been seeing.
Thank you. So the next one I think has been answered, like when you were talking about your project, was to be consider high protein or high fat amounts. So I guess that we answered that, or do you have anything you want to add or?
For the definition of high protein, high
Yeah.
fat, yeah, I think we answered that during the presentation, but if something is still not clear, please feel free to send more
Then
details.
another participant is asking, will biosimilar insulin have the same effect as insulin presently available?
That's a hot topic. Briefly, in average, yes, it's the same effect. The problem is it true for each individual. So, of course, you know how diabetes is fluctuating sugars, things happen you're not expecting. When you change insulin because you're forced to because it costs less and things are not going well, are you simply using this as an excuse saying, aha, that's the reason? Or is it a true effect? I don't know. But certainly I can say there's an enormous number of people that have been forced to change that are complaining, certainly to me and my patients. But unfortunately, the ways to go around that are limited. Like the government, it has to be a physical allergy to the biosimilar to be able to take the original one. So there are certain tricks to go around. Some of these insulins, like the more concentrated ones, don't have a generic, so there's no biosimilar. But in general, most people seem to be doing okay on the biosimilar.
Thank you, Dr. Yale. And we have a question on insulin resistance. Can you comment on insulin resistance and how this relates to the strategy of dosing insulin? For example, high-fat diet is related to higher insulin resistance. How do you account for this?
I guess I can
Meryem,
go a
yeah.
little bit for this one. So yeah, yes indeed, when we consume a high fat meal, there is also that component of insulin resistance with the fatty acids after consumption. But it is actually taken into account when we say that fat will lead to a more sustained, a more delayed hyperglycemia. So it is one of the factors that causes that delayed hyperglycemia or that delayed rise that we're bringing up today. Yeah, it definitely does impact.
Thank you, Meryem. And then here we have someone asking, I'm used to be on Novorapid and now I'm on Apidra. I see a difference in how my glycemic rise happens. So all the strategies I used earlier, like pre-bolus, have now all changed. Is there any sort of clear, simple info available of the different insulins and their impact?
The problem, as I said before, is that all these studies suggest that in average, they're doing exactly the same curves, etc. So it's really the same recipe that's being applied. Now, as I say, some people say that that's not what they feel is happening in their life. So there's not really simple info. I think if you're on a pump, often you can still get the original ones because there's little studies of biosimilars with injection with the pump. If you're on injections, usually the government and more insurance companies will request that you use the biosimilars. With the insurance companies, sometimes we can ask if try to make a case to go back to the original. With the government, it doesn't work unless you have an allergy. So You have to relearn. If you feel your strategies are slightly different because you've changed insulin, you might have over time to relearn whether you're on Apidra, which is not a biosimilar, but if you were on Turapi or if you were on analog, the biosimilars, it would be the same concept. So when you change insulin, the recipes might change slightly.
And I think there is a resource on Type 1 Better website about biosimilars. Maybe Sarah or Natalie can take the link and put it in the chat. I think it's a great place to start going through what the different changes might be.
Yeah, Sarah did put the link in the chat.
Oh, nice. I see there is a hand raised. I don't know how we.
Oh, you see hand raised? I don't know. I don't see them. We still have two questions. Maybe we can try to answer them like very quickly. So there's one on LADA, and the person said, it seems as though on certain days, the same meals seem to affect my glucose differently, either high or low on different days. Is this when it's best to split my insulin doses?
So when you have LADA, you really have physiologically a type 1 diabetes, but perhaps sometimes with some remaining insulin secretion by your own pancreas at the beginning. So it's simply type 1, which occurs very slowly over time and therefore often appears late, so late onset at that point. Now, a lot of things affect glucose levels. So it might be when you're higher certain days because you're more stressed that day. It might be because you have less physical activity. So there's many more factors. And the problem with splitting your insulin dosages is that you often will know if you're in a high or low day on what happens after your meal. But will you know before the meal what will be the response after the meal? So that's where it's just part of the variability that you see, and where you either have to correct when you see it's high by giving a correction dose, or if you have a automated pump, automated insulin delivery pump, then it will be able to do it for you.
Thank you, Dr. Yale. Then the last question is about the diagrams on the slice of pizza. He's saying that I do eat every 3 to 4 hours. How does that interfere, or how to monitor in that case, applying your suggestions?
I guess I can take this one.
Yeah.
So eating every 3 to 4 hours, sometimes the changes in glycemia from the previous meal might still be in fact when you're trying to eat the new meal. So that's why on times we recommend checking your glycemia before eating the meal and taking into account that with your correction factor. But also the insulin on board. So sometimes the insulin that you gave, some of it might still be there, and you don't want to end up, stacking insulin over insulin and increasing your risk of hypoglycemia. So what I could do is just looking again at the trends when you eat like every day, what the changes that you usually do and how that impacts you, and just based on that, seeing what could work for you. But really, it's again like what we are recommending in terms of the consensus as well as in the literature. It's a starting point. There are so many different things that can impact your glycemia if you had physical activity before, if you're consuming alcohol with your meal, so many things that can impact it. So it's really something to discuss with your team, with your information. I don't know if Dr. Yale wants to add something to that.
Very complete.
Well, it's 1:48, so we must take this to an end. So thank you very much, Dr. Yale, Meryem, for this great presentation. I hope you all liked it. It will be available on our website later today for those who want to look at the replay and see all the slides and stuff. So thank you again very much for being part of the Better Registry. We really need you to get to know T1D a little bit more better. So thank you very much and have a nice day. Bye-bye.
Thank you. Bye-bye.
Bye-bye, everyone.